Right, so we were discussing question number 4. Question number 4 says that a 54-year-old man was admitted to the hospital with complaints of sudden intense headache in the occipital region, right? And patient is also having vomiting. Now, when I tell you that there is intense headache which is accompanied by vomiting, you might think the option as migraine. Okay, but let us read the question. So look at the history. Moderate arterial hypertension, the patient was taking hydrochloroside, right? But in case of migraine, there is no such medical history. Okay, there is no such medical history. And but here in this question, there is a medical history of hypertension and the patient is already taking hydrochlorothiazide. So if you have remembered, I already told you in the first question that if the option has to be hematoma, subdural hematoma, then definitely the patient will have a history of hypertension. And consciousness is confused, left pupil is mydriatic, photophobia, tension of the neck muscles, left side hemiparesis, right? So all these symptoms are there. Now you might also think that the patient is having, by seeing this tension of neck muscles, photophobia, vomiting, occipital region, headache, you can think of bacterial meningitis. But in meningitis you will have fever. But look here, the body temperature is low, no fever. And even in meningitis you will have a chance of having rash, but here the rash is absent. So first of all, you need to differentiate between what is subdural hematoma and what is epidural hematoma. What is the difference between subdural hematoma and epidural hematoma? Now when it comes to subdural hematoma, in the subdural hematoma the patient will be having loss of consciousness. Second important thing, in patient will be having pupillary changes, pupil changes, right? And third important thing is patient will also be having hemiparesis. So these are the complaints basically. So patient here is having consciousness is confused, right? And he's having pupillary changes as well, that is the left pupil is mydriatic, and he's having hemiparesis. See, left sided hemiparesis. Along with patient is having severe headache and also a history of hypertension. So this is so clear that the patient is having subdural hematoma. Coming to epidural hematoma, if they remove one of these options and put epidural hematoma there, now you should not be confused between these two hematomas. In epidural hematoma, patient will be having lucid interval. Lucid interval. Now what do I mean by lucid interval is that, see, when patient had hematoma, obviously he will go into unconscious. He will have loss of consciousness. Now after regaining from the loss of consciousness, after when he becomes conscious, right, he'll do his work normally, and again suddenly he'll be unconscious, and after that for a brief period of time he will be unconscious, and after that again he'll be conscious. So this interval in between is called as a lucid interval, which doesn't happen in subdural hematoma. So such case is also not given here, right? Next thing is disseminated sclerosis. So most probably disseminated sclerosis means scleroderma, which we'll be discussing in the later on questions, subsequent questions, very detailed. Myasthenia, as I told you, in myasthenia there is no point of tension of neck muscles, there is no point of pupillary changes, there is no point of hemiparesis, so photophobia, such things don't happen in myasthenia. Myasthenia is mainly it affects the skeletal muscles, not even the smooth muscles. So it is not migraine as well, because in migraine we haven't seen pupillary changes, we haven't seen hemiparesis, we haven't seen loss of consciousness and all, right? So I hope you understood this question. Now let's go on to the next question. A 51-year-old woman was taken to the emergency department in convulsive status epilepticus, right? She is having epileptic status. Now what medical management you should do? See, any patient who is unconscious, what is the first thing you do? You check the ABC. You remember the rule: airways, breathing and circulation. So first thing what you need to do is airways. Here he has the first means, that is airways. Check the airways. But anyways, what is status epilepticus? Status epilepticus is defined as epileptic seizures which are occurring more than or equal to 5 times in a day, or other definition is lack of recovery. I can tell, right? Lack of recovery, or you can also tell that lack of consciousness. Lack of consciousness between 2 seizure attacks. It means now the patient will have a seizure attack, right? So suddenly the patient will fall down, he will be unconscious, he will be having a seizure attack. After that, for a brief period of time, the patient will not regain his consciousness. He will remain unconscious. Again, he will have another seizure attack. It means between 2 seizure attacks, the patient is still unconscious. Or another thing is, if he is having more than or equal to 5 seizure attacks, more than or equal to 5 times, not 5 times, I'm sorry. If the seizure attacks last for more than or equal to 5 minutes, right? If the seizure attacks last for more than or equal to 5 minutes, then it is status epilepticus. And what is the most common cause of status epilepticus? It is because of the stroke. And what is the treatment you give for this patient? Treatment you give is lorazepam, diazepam. You also give phenytoin, fosphenytoin, valproic acid. Now these are the first line. These group, lorazepam and diazepam, are the first line. Okay, so this is all about the discussion of the 5th question here. Let's hang on to the next question. Now, a 38-year-old man complains of having occasional problems with the swallowing of both hard food and fluid food. Now, even in the surgery also, there are many questions, I mean not many, around 4 to 5 questions which are based upon the same concept. So he's having problem for taking hard food, I mean the solid food and the liquid food. So sometimes he feel intense pain behind his breastbone, especially after drinking the hot drinks. There are asphyxia onsets. At night he has not put off weight. See, if you find in a question that there is no change in the weight of the patient, then you need to exclude the first thing, that is cancer. So malignancies are always associated with weight loss, unexplained weight loss, gradual, not gradual, sudden weight loss, you know. So his general condition is satisfactory, skin color is usual, examination no changes, gastrointestinal tract, X-ray picture shows thoracic organs present, dilation with the level of fluid. You know, basically if someone is not able to take, either it might be a solid food or a liquid food, if he is not able to ingest, then you need to classify it under a condition called as esophageal dysphagia. Patients with esophageal dysphagia, sometimes patients cannot eat only solid foods, sometimes patient cannot eat both solid food as well as liquid food. So if a patient comes to your clinic complaining that, doctor, I cannot eat solid foods, then you need to ask, are these symptoms for you, are these symptoms are intermittent, or are these symptoms progressive? Even here, are these symptoms intermittent or progressive? If he tells that, doctor, the symptoms are completely intermittent, only sometimes I do, I can't, but most of the time I eat solid food, but sometimes I can't eat solid food, then it will be lower esophageal sphincter problem. If it is progressive, then it can be a stricture or it can be a cancer. Okay, and next, if both solid and liquid food is not able to take, then you need to think of remaining problems. What are the remaining problems? If it is intermittent, then it can be diffuse esophageal spasm. If it is progressive, it can be achalasia or scleroderma. Now this table is very important. So based upon this table, you can easily crack any question that is asked regarding this esophageal dysphagia. Now look at this question. He can't eat hard and fluid food, solid and liquid food. It means he's talking about this condition over here. Now let us see, are the symptoms intermittent or progressive? Hard food and fluid food for many months. You see, he cannot eat hard and fluid for many months. It means the symptoms might be progressive. So in progressive, what are the two things? Achalasia, scleroderma. Now do you find scleroderma here? No. Do you find achalasia? Yes. Option A. Right. So I think I have to cancel option C because patient has no put of weight, so cancer of esophagus is wrong. I even have to cancel myasthenia because myasthenia mainly affects your skeletal muscles, not the smooth muscle. Now what is GERD? Let us discuss some important things about GERD here. As you know, GERD is gastroesophageal reflux disease. This is your esophagus and this is your stomach over here. As you know, the lower part of the esophagus has got a sphincter. Now this sphincter here, this is called as lower esophageal sphincter, which has a pressure of about 20 mmHg. Now in some conditions it might happen like this, that the lower esophageal sphincter might not work, so that it cannot maintain such perfect pressure. I mean, the pressure of the lower esophageal sphincter, sometimes it turns out to be less than 20 mmHg. So when it will be less than 20 mmHg, the sphincter cannot contract properly. So the sphincter fails to contract or constrict. So when the sphincter fails to contract or constrict, what will happen? The food material which is in the stomach can regurgitate up into the esophagus. So patient will be having pain, heartburning pain. When he'll be having heartburning pain after eating the food, so you call it as postprandial heartburn. Postprandial heartburn. So patient will be having postprandial heartburn. So this is the most highlighting and tempting feature which the examiner will be giving you in the case. Postprandial heartburn. Now in this GERD patients, there is a problem with the sphincter. Now how do you diagnose this patient? What is the gold standard? The gold standard is 24-hour pH metry or 24-hour pH monitoring. 24-hour pH monitoring is a gold standard for the patients who are suffering from GERD. Now another important thing which you need to take into consideration is that not only this, even in case of there are also two more important conditions like Crohn's disease and ulcerative colitis. Now in these conditions like Crohn's disease and ulcerative colitis also, you will have different representation of the problems. So far in case of GERD, the diagnosis is 24-hour pH metry, and if I have to treat the patient, what will I do? There is a problem with the sphincter, right? So what is a thing which I do here is sphincterotomy. Sphincterotomy is the first important thing which I decide to do, right? Now if the patient is not ready for the surgery, then instead of doing this sphincterotomy, I can do one more thing, that is I can give the patient drugs. Now what are the drugs that I can give? There is a lot of acid, right? So I can give the patient PPI or I can give the patient H2 blocker. Now you know the names of the drugs. You know, ranitidine, famotidine and PPIs are omeprazole, pantoprazole. Right. So this is all about the discussion of gastroesophageal reflux disease. Esophageal candidosis, no. Esophageal candidosis cannot be the option. There is oropharyngeal candidosis. I don't know what is esophagus candidosis. Maybe in Ukraine we have esophagus candidosis, but worldwide we have oropharyngeal candidosis. If really there is esophageal candidosis, I'm sorry, I don't know about it. So this is all about the discussion of question 6. Coming to the question 7. Now question 7 says that a 35-year-old woman consulted a doctor about, you see here, occasional pains in the paraumbilical region and iliac region. Not continuous pains, there are occasional pains. And she also tells that the pains reduce after defecation or passage of gases. Pains are not continuous. So when she will pass the gas, it means when she will defecate, the abdominal discomfort is gone, the pain is gone. And when she'll pass the gas, when she'll fart, then the abdominal discomfort is gone. This gives relief to the patient, right? After defecation and after farting, it gives her very good relief. And another thing is, this happens 6 times a day. Stool is not solid with some mucus in it. She has not put off weight, so then there is no point of thinking about the cancer, right? So, and colonoscopy data reveals no changes. Now, these are some of the important things which you need to keep in mind. Now, let's go on to the question. However, the answer which is given here is irritable bowel syndrome. Now, first we'll be discussing what is irritable bowel syndrome, and later on we'll come back to that point here. Now, coming to what is irritable bowel syndrome, the definition of irritable bowel syndrome is patient will be having abdominal discomfort. Abdominal discomfort in the sense a feeling of bloating, feeling of meteorism. Meteorism means gas in the abdomen, okay? Gas in the intestine. Feeling of bloating, feeling of meteorism, feeling of fullness, and feeling of some sort of pain in the intestine. So all of this include the abdominal discomfort. So abdominal discomfort in the patient, right? Abdominal discomfort in the patient. How many times? At least once a week. At least once a week for about 3 months. Is that enough? No. At least once a week for about 3 months, always associated with relief on defecation. Relief on defecation. And second thing is change in nature of stool. Third thing is change in frequency of stool. So if a patient is complaining that doctor, I have abdominal discomfort in whatever form it might be, I have abdominal discomfort once a week, and this is happening from 3 months. And along with that, doctor, whenever I defecate, the pain is reducing. And every time when I defecate, there is a different nature of the stool, and there is different frequency. Sometimes I get in the morning, sometimes I shit in the evening, sometimes I shit in the night. So if you listen those complaints, then definitely the thing is about irritable bowel syndrome. If you wanted to do a colonoscopy, which is not at all needed, if you do a colonoscopy in these patients, you don't find any changes. You don't find any changes in the colonoscopy. Colonoscopy will be absolutely normal. So this is irritable bowel syndrome. Now, what is the concept of, but before discussing the option B, I also want to tell one more thing, that the exact opposite of irritable bowel syndrome is inflammatory bowel disease. Exact opposite of irritable bowel syndrome is inflammatory bowel disease. Now what is this inflammatory bowel disease? In inflammatory bowel disease, you have got two things. One is called as Crohn's disease, another one is called as ulcerative colitis. One is called Crohn's disease and another one is called as ulcerative colitis. Now what is this Crohn's disease? Crohn's disease is, there will be in both of them, in the Crohn's disease and ulcerative colitis, in both of them there will be inflammation of your intestine. Okay, but in Crohn's disease the inflammation can be anywhere. It can be anywhere. It can also be anywhere. It means from the mouth till the anus. From the mouth till the anus, anywhere the inflammation can happen. There is no rule. But most commonly the inflammation happens at the terminal ileum. Most commonly the inflammation happens to the terminal ileum. Okay, so this you see in case of Crohn's disease. And in Crohn's disease, when you do the colonoscopy in the Crohn's disease, what are the features which you find? Whereas in irritable bowel disease you didn't find any features. Now when you didn't find any features in case of irritable bowel disease, you have to find some or the other changes of colonoscopy in case of inflammatory bowel disease. So one thing you are sure, that irritable, no colonoscopic changes, but in inflammatory you will have colonoscopic changes. Colonoscopic changes are present. This is the most important difference. This is the most important difference between the irritable bowel syndrome as well as the inflammatory bowel disease. Okay, and okay, when you look at the Crohn's disease, what are the colonoscopic changes which you find? In Crohn's disease, when you put the colonoscopy and see the colonoscopic changes which you find is, look here, let me draw a small picture. For example, this is some part of intestine. Okay, when you look at the colonoscopy, however, I told you the inflammation can happen anywhere. So the inflammation can happen here, the inflammation can happen here, it can happen here, it can happen here, here. So the inflammation exactly can happen anywhere. But one thing is for sure, as the inflammation will not happen continuously. There is discontinuous. You see here, the discontinuous. So these lesions are discontinuous. So I can call them as, these lesions as skip lesions. I can call these lesions as skip lesions. And such appearance which I find on colonoscopy is called as cobblestone appearance. Cobblestone appearance I find on colonoscopy. Okay. Now, if I am not treating this patient, what will happen? Of course, he will develop complications. What complications he can develop? He can develop abscess. He can develop fistulas. Abscesses and fistulas are the most important complications in Crohn's disease. Now, coming to ulcerative colitis, in patients with ulcerative colitis also the inflammation can be anywhere in the intestine, but as the term says colon, so most commonly the inflammation resides in the colon. That's why called as colitis. Now let me make a small picture of the intestine here. Now this is your ascending colon, the part of large intestine, and this is your transverse colon, this is your descending colon, and this is your sigmoid colon, and here you have your rectum and anus, right? Now here the inflammation basically starts in the rectum. Where is the first site of inflammation? The inflammation starts in the rectum, and this inflammation from the rectum, what will happen is it can prolong, or this inflammation can spread upwards like this. You see, it can spread in such a way that it can affect your entire colon. when it affects your entire colon, you call this condition as pancolitis. Okay, when it affects your entire colon, you call it as pancolitis. But where does the primary infection start? It starts in the rectum. Now at some point it might happen like this, that the entire colon becomes like this. You see? Now these depressions which you can see here, these invaginations or depressions here, these are called as haustra. Now as there is inflammation everywhere, in the colon, the haustra are lost. No, the haustra is lost, right? Why? Because the inflammation in the colon is continuous, right? So here I call it as skip lesions, but here I should call them as continuous lesion. Okay. Now as a result of skip lesion, I have got cobblestone appearance, but here the entire intestine, not the entire intestine, the entire large intestine or the entire colon has become like a pipe. So I have to call it as lead pipe sign. Lead pipe sign is a characteristic feature of ulcerative colitis. And what are the complications which I develop here? For example, see here, one thing you know, that when the haustra are lost, when the complete colon has been inflamed, will there be any peristalsis? Absolutely wrong. There won't be any peristalsis. So when there is no peristalsis, the digested food which is ready for excretion, as there is no peristalsis, it will stay in its own place. So the next food, when it comes, it accumulates, and at one point what basically happens is your entire colon size increases out like this. So here you have a lot of food that has been obstructed. So the colon has become very large. Now this condition or this complication is called as toxic megacolon. This is the most important complication. Another most important complication is patients can also have colon cancer. Ulcerative colitis patients are at higher risk for development of colon cancer. So that is the reason why we should generally tell the patients who are suffering from ulcerative colitis to have their colon get scanned at least once in 8 years. Okay. And another important thing which you need to, I forgot, is what type of abdominal pain you have in Crohn's disease. You have crampy abdominal pain. Okay. And in ulcerative colitis, what is the important feature? You have stools which are hemorrhagic stools, right? Because there is inflammation, moreover in the rectum, so obviously the blood oozes out. Now what is the treatment you give for both of them? The treatment which you give is, for both of them, the same treatment is 5-amino salicylic acid, 5-ASA, 5-amino salicylic acid. For example, sulfasalazine. Second line is you give corticosteroid to the patient, and third is you give iron supplementation. These are the important things which you give. Okay. So now I hope you understood why the option is not C, why the option is not E. Or E, what is pseudomembranous colitis? It is ulcerative colitis. And the option D, what is celiac disease? What is celiac disease is, in patients with celiac disease, what is the most important thing which you find? You know, from your KROK 1, you already know that celiac disease is mainly because of gluten sensitivity. right? Celiac disease is mainly because of gluten sensitivity. Now in this celiac disease, now instead of discussing all the things, two important things I want to tell you is that celiac disease patients definitely they will have mouth ulcers. Definitely. If in a question, if we wanted to ask you about celiac disease, 110% he will be telling you that the patient had mouth ulcers. Second thing is dermatitis herpetiformis. It means patient will be having a rash, and this rash is in the form, how does the rash look? It is in the form same like a herpetic rash. That is why it is called dermatitis herpetiformis. Herpetic form like rash, so you call it as herpetiformis. Okay, now where is this rash located? This rash is located on the shoulders, it is located on the elbows, even on the knees. So in this question he has not given any complaint of mouth ulcers, any complaint of rash, so even option C is also wrong. Dyspancreatism in the sense pancreas are not able to release enough amount of enzymes. For example, what are the enzymes that are released by pancreas? Exocrine function is release of protease, amylase and lipase. So if they are not released the blood, then there is no if they are not released into the duodenum, then there is no digestion within the duodenum. Okay, so this will cause steatorrhea to the patient. So there is no complaint of steatorrhea or anything. So I hope you understood this question very well. Question number 7 is done. Look at the question number 8. Look at the question number 8 here. The physician must undertake measures for primary prophylaxis. It means prevention of iron deficiency anemia. So you know most commonly who are affected, which group of the patients are affected with iron deficiency anemia? Patients, or mainly the pregnant woman. Definitely she will have iron deficiency anemia. So you need to take some prophylactic measures and give iron supplementation during the pregnancy. So that is all about the 8th question, right? Now the remaining questions we shall discuss it after the break.